So we talked about what do you do when someone relapses after adjuvant therapy. What if someone presents to you de novo who's never had adjuvant therapy or had adjuvant therapy years ago? How do you decide whether, let's say, in a BRAF mutated patient, who gets BRAF/MEK, who gets immunotherapy? Is it single agent? Is it dual agent? How do you make those decisions, and how do you present it to the patient?
Yeah, so that's a very good question. And again, just to back up a little bit, I do think that the adjuvant therapy is kind of defining new phenotypes of metastatic melanoma. So all of our currently approved therapies have been proven in a setting when there was no adjuvant therapy. All of the clinical trials that have been conducted that led to approvals were phase 3 randomized trials, every single one of them in the first-line setting in previously untreated patients, which gave us really great data and gave us great agents in our hands and at our disposal now to treat our patients. But unfortunately, targeted versus immunotherapy has never been compared head-to-head in the first-line setting in melanoma to date. There are ongoing trials that have tried for several years to answer that question, but at this point we don't have the answer to that. And so in general, what we do know in the first line setting for metastatic melanoma is we have single agent nivolumab, we have single agent pembrolizumab that have both have substantial response rates and improvements in overall survival. We also have combination immunotherapy of ipilimumab and nivolumab that improves response rate, seems to improve PFS, has a modest impact on overall survival, but also comes at the risk of a doubling, if not a tripling of the toxicity rate. And then for BRAF mutant patients, we have now 3 combination therapies, dabrafenib, trametinib, vemurafenib, cobimetinib, and encorafenib and binimetinib, that are all also proven to have a substantial response rates, a significant impact on PFS, and improvements in overall survival. So when a BRAF mutated patient shows up, I have a lot of choices to choose among. I think we all kind of separate this into 2 kind of general questions, immunotherapy or targeted therapy. We do think that immunotherapy has kind of the more durable impact in general, and we, in case we don't have clinical trials specific for that population, we can consider single agent immunotherapy or combination versus targeted. A lot of the times, both from patient's preference, and I can tell you in our institution, we kind of veer more towards immunotherapy. Then we start asking the question, do you do combination versus single agent? And in those kind of situations, we really take a lot of clinical characteristics into considerations. Are these patients with a high tumor burden? Are these patients with a high LDH? Importantly, as we're going to discuss later, are these patients with brain metastases at the time of diagnosis of metastatic disease? Those things can actually push us towards using ipilimumab and nivolumab in combination if you have a high tumor burden, high LDH, and definitely if you have brain metastases. In patients that have a low LDH, low tumor burden, again, single agent immunotherapy is a reasonable approach. At our institution, we tend to keep targeted therapy for the second line, although there is no data for BRAF/MEK in the second line after PD-1 resistance. There is very specific situations where some patients can have, as we discussed earlier, autoimmune disorders. We're still trying to understand in those populations the safety of immunotherapy and how effective it can be. That may kind of points us more towards targeted therapy.